are at HIMSS 2018. This is David Harlow bringing you dispatches from the front, from the exhibit hall. I'm speaking with Michael Nissenbaum, President and CEO of Aprima Medical Software. Good afternoon.
Good afternoon.
Pleased to speak with you today. So I understand that you have been in the EHR space, and now we are really looking at beyond the EHR as we may have thought of it way in the past, and it's really one in a quiver of tools around physician workflow. We're really sort of growing the idea of what is the EHR, what are the toolkit that a physician needs in order to manage his or her practice effectively. So I wonder if you could tell us a little bit about the core tools and the additional tools that you have added on beyond that, and how you see that helping your customers.
Thank you, David. There's a number of ways of looking at it. You know, an EHR has always been a data collection tool. And by doing that, it was basically taking many of the items that physicians put on paper and just recording them electronically.
Right.
Now we are transcending into a time and place where we're now taking data, aggregating data, analyzing it, and then using it back into the practice as an adjunct to the physician's decision-making capabilities, which may give them guidance, which, you know, like all of us, they see the same 3,000 patients a year. They may be narrowly focused. They may not be as attuned to some of the new protocols. Yesterday we had a great meeting with our partner, ActX, which is genomics, and the idea of treatment has moved from data aggregation to assembling these vast resources of data and using them to both diagnose and treat the patient, which is the charge of the physician. And then the second transition is empowering the patient to have access to data and to monitor their own data, whether it's something as mild as a Fitbit or the cardio indicator in the new watches that can monitor your blood pressures and be proactive. And so care is no longer just episodic. It's moving into a constant and continuous relationship with the healthcare provider.
Right. We don't necessarily want to have every bit of data go into a physician's workflow. So a physician says, that's great, you're taking 10,000 steps a day, I don't really care. I don't need all of that in my workflow. Are there filters that you're able to build that a physician is able to customize in order to say, I do want this Fitbit or I do want this cardio monitor information, but only if it goes out of bounds.
Yeah.
So there's a gating function to all this data.
Let me give you the yin and yang of that, if you will allow. I understand the idea of, am I doing my 10,000 steps? One of the things many of us have always said is, yes, when we go to the doctors, some of us have been known to lie about what we're doing.
Shocked.
You know, we're not eating, a pint of ice cream at a sitting. We don't report that. But with a physician being able to say, I'm a diabetic, I'm supposed to be eating healthy and walking, but I'm just relying on what you say, may result in a different treatment protocol than if I have evidence that you were doing it. And that could enhance. But the second one is with our partnerships with SureScripts, and we help pioneer the meta-adherence program with them. So we know if the patient has actually gone and gotten that prescription. Now we can't validate whether they put the pill in their mouth or the syrup down their throat, but at least we know that they're not leaving the prescription in the glove compartment of their car and ignoring that. We know that they picked it up and that we've done our part to get them to as close as possible. And if the patient comes back with a relapse or a worsening in condition, and we have some confidence from these data points, maybe not the entire spectrum of it, but some validation, it will allow us maybe to modify the next treatment protocol that we put in front of the patient.
Sure, make better decisions
exactly.
based on what actually happened.
Exactly, and have some evidence support it other than the patient saying, I did that. As Ronald Reagan said, trust but verify.
Right. So do you see part of the, back to the workflow question, are we able now to get the physician out of the chair with the back to the patient, hunched over the computer screen, or are we still tied to that model?
Well, I look at different applications. We're moving more to mobile devices so that the physician can have eye-to-eye contact with the patient and doesn't have to be in a chair with the back to the patient. While I understand the physician's concern with that, I just remember 10, 12 years ago, before my physician of 31 years retired, and she would sit on her little stool with 31 years of data in a 5-inch folder and no indexing, and look at me and say, when did we last do a tetanus shot, any type of inoculation, an x-ray? And I became the EMR because she had no idea in that stack of paper where to go.
Right.
And while you may have your back to me, I know that what you're looking at has the detail that you're going to turn around and say, well, let's go get a chest x-ray because you last had one in 2006, as opposed to when the hell did we last do it? So it's give and take. I think more of the EMRs now are becoming a conduit for conversation between the patient and the provider. And some of our practices have put large monitors on the screen so that they can observe the engagement as the doctor is going through and documenting. And in fact, some cases say, that's not true if the doctor is making a comment or an assumption that the patient doesn't agree.
Before it's committed to
right.
Written in stone. How has the evolution towards interoperability affected your work, your practice in your company? Do you see more of a demand for it from the individual customers that you serve? How does it affect the relationship with the customer?
If you see this big bruise on my forehead, it's from my hitting my head against the wall about interoperability. It is something that is so needed. It would allow healthcare to be so much more efficient and so better delivered. And we are working with SureScripts now. We're bringing to market on their application National Patient Record Locator function in April. Now, SureScripts has a very large footprint, so we should be able to obtain a vast amount of data. But there's still competitors in this hall that build a moat around their particular system and make it very difficult to transcend that moat and get the information on a contemporaneous basis. And that's just disingenuous. It harms the patient and it harms the provider and increases the overall cost of healthcare. We are strong advocates. We belong to Commonwealth. We've done FHIR development. We are so open to continue advocating this initiative. And personally, I think if Congress would ever say, if you do not have an interoperative system without limits, you don't get Medicare reimbursement. How fast would that break down walls?
Right. So they've moved somewhat in that direction, not to that degree with the 21st Century Cures Act, and now there's this trust framework that's out for comment. We'll see whether, given the current political environment, we'll be able to bring that across the finish line.
Your lips to God's ears.
Well, it's great speaking with you. Thank you very much for
Likewise.
taking the time.
Thank you very much for coming to our booth and visiting with us.
A pleasure. This is David Harlow signing off at HIMSS 2018.